So really interesting and really important topic to be discussing tonight. I'm Yvonne Zurynski. I'm Professor of Health Systems Sustainability at the Australian Institute of Health Innovation at Macquarie University. And I'm joined today by Christina Rojas, who's at the back. She's the main organiser. Thank you, Christina, for organising us. And Dr Lauren McKnight, sitting there in the corner. Thank you, Lauren. Lauren's doing a bit of observation and evaluation for the workshop for tonight. And we're all part of the Rare Disease Awareness, Education and Support and Training project. And I'll tell you a little bit more about that as we go through. But first, I'd like to acknowledge the Whadjuk Noongar people, the traditional custodians of the land on which we meet today, and pay our respects to their elders, past and present. We also extend that respect to Aboriginal and Torres Strait Islander peoples attending here today. And we acknowledge the traditional custodians of the various lands from which you all come today. We also acknowledge the traditional custodians of the land on which Macquarie University stands, the Wallumattugal clan of the Darug Nation, which is over east in Sydney. And we have a beautiful campus. If you ever have the chance to come to Macquarie University, give us a call and we'll welcome you very much. So the agenda for tonight is essentially to do some introductions and acknowledgements, and then to hand over to our collaborators, the Rare Care Centre, and Kaila Stevens from the Rare Care Centre will be presenting on that. It's a really amazing new model of care that's been developed here in WA. It's a really innovative model, and we would love to see more of that kind of model of care being implemented, not just in WA, but across the country. And then we have some very special guest speakers, people with lived experience. So Andrew, Amanda and Cristian will give us some talks, and we're really looking forward to that. And really thank you so much for agreeing to do that. We always learn lots of really amazing stuff from people with lived experience. So thank you. All right, so the RArEST Project, Rare Disease Awareness, Education, Support and Training, is a collaboration between Rare Voices Australia, the Uni of New South Wales, University of Western Australia, Macquarie University. And the project is really a key initiative under the National Strategic Action Plan for Rare Diseases. If you haven't looked at that plan, I suggest that you use the QR code or go onto the Rare Voices website and have a look at that plan. It's the very first plan for Australia on how to address the many issues that face people living with rare disease. There are 3 streams. Stream 1 being supporting individuals, including supporting mental health and wellbeing. Stream 2 is the health professional education, support and training. And you'll see on the table at the front that we have the first recommendations for rare disease care. And that's a really huge advance that RArEST has achieved, which is fantastic, led by Emma Palmer from University of New South Wales. And we are in Stream 3, so we're more around, the co-design approaches, awareness to education, and the sort of systemic improvements. How can we improve the systems that you'll see are quite complex and hard to shift? So I'm from the Institute of Health Innovation. We want to co-create high-impact health services and systems research that drives positive change in policy, practice and behaviour for the benefit of all. So we're a different research institute. We don't splice genes, we don't develop new tests, we don't develop new drugs. We look at systems and how we can improve care and how care is delivered, how we can improve quality and safety in healthcare. We have 4 main centres across the institute. So Centre for Healthcare Resilience and Implementation Science, so that's how do you make changes and implement them and sustain them. Centre for Health Systems and Safety Research, so that's that quality and safety part. Centre for Health Informatics, because increasingly health is reliant on e-technologies and informatics. And of course, you can't go anywhere without health economics. Money talks, so they're really important colleagues to us to have the health economists on board. And then we have some other centres that are not permanent centres within the Institute. So, we're talking about systems today, and often when you think about a system, you think about, well, how is an organisation organised? How does this system look? What's it look like? Does it look like this? And we tend to draw really nice, ordered hospital organisational charts, with the CEO at the top and various hospital departments, etc. It's kind of like that, but it's more like this. So this is just one shift in one emergency department. This is what happens in healthcare. It's complex, it's complicated, lots of moving parts, lots of different people involved. And you need coordination, and you need communication, and you need the right data, and you need the right skills and the right personnel. So when we think about complexity, things can be, the complexity is based on the degree of interrelatedness and the number of components. So the more components you have in a system, and the more interrelated or interconnected they are, the more complex it gets. So if you have few components and not much interrelatedness, they're not too connected, you've got a simple system. But if you've got high degree of interrelatedness and high number of components, you're in a complex system. And also, those systems are made up of different agents, so all the people within the systems, different services, organisations, policies and structures, and governance and cultures. And it's all interrelated. And not only that, it's ever-changing. Policy always changes. And it evolves and it adapts, as do systems. And so, systems respond both to the internal and external forces. And sometimes our colleagues in the health system, the clinicians, say, well, our political masters have decided that now we must do this. And the system needs to respond. Whether it's right or wrong, the system needs to respond. And that's what we call complex adaptive systems. The system changes and adapts to different forces and different drivers. Okay, so if you think about, healthcare, a simple system might be making an appointment. That's fairly simple. You need to go and see your endocrinologist or your cardiologist or whoever might be. You might need to use some complicated equipment, and things might get really complex if you're in the operating theatre. You've got lots of people working as a team, using lots of different equipment, high risk involved. What we want to avoid at all costs is the last one, chaotic, when the teams don't work together, when the teams don't understand what each other is meant to be doing. And that does happen, unfortunately. The other thing I want you to keep in mind is that the health system is not a system on its own. It's actually composed of a technical system, the work processes, facilities, devices and equipment, a social system, so it requires people to work together. Those people have cultures, organisational structures and collaborations and hierarchies. They should be doing shared decision making, but sometimes that doesn't happen. And it's an economic system. And of course, all around that are the forces that influence this. So when you're thinking about the health system, it's actually a number of different systems that are interacting with each other. And so that's why it's complex. So the Australian health system, I'm not sure how many of you have seen this picture. It's been around for a while, but there's many different layers, and I don't want to go into it because it would take me half a day to explain it. But there are different flows of funding. The funds are not necessarily aligned in a logical way. So there's state funding, federal funding, there's funding for different tiers from different sources, and it all needs to work together somehow. The other thing that really stymies us is our federated system. So heaven forbid should you be living near a border and your nearest specialist services are in the other state. It becomes really difficult. Your records can't be shared across that border. you guys are doing really well in the West, and in a way, this is working for you because you're isolated to some extent, and you're kind of masters of your own domain. There's a lot of innovation happening in WA, and we're always really envious. You've got one kids' hospital, fantastic. One PHN network, brilliant. So, when you're working with the primary healthcare sector, you go to one PHN. We have too many of them. We have to negotiate. And that's where the complexity comes in. It's very hard to make change when there are lots of different players. So to some extent, you're ahead of the game because of that. Okay, so sometimes when we think about what happens in the system, really doesn't. So we looked at one, I'll show you one example. It's about Lynch syndrome, which is a rare form of colorectal cancer. It's associated with a genetic anomaly. And when we asked oncologists, what they thought happened in the system, they said, okay, well, it's easy. We screen, we identify people at high risk, and we refer. No brainer, right? This is what actually happened. So it's not as straightforward. They thought that only 1 or 2 people would be missed and not referred. Well, actually only 2 out of 14 were referred. So lots of people missing out on referrals. They thought that people wouldn't be going to private clinics. Well, they were. They thought it would take a long time to be seen. That wasn't the case. So, when you actually unravel it and have a look at how things work, you'll find that work as imagined, what you expect is happening, doesn't necessarily happen. And it's really important to know that if you're trying to change the system. All right, I might grab Lauren to explain this slide. Thanks, Lauren.
Thanks, Yvonne. Lovely to see you all. So I'm Lauren, I'm the evaluation lead for the RArEST Project, and that means that I have the incredible privilege to work across all 3 streams. And what I've actually really loved about working with Stream 3 is that we get to take a much bigger and holistic look. Yvonne's mentioned some of the complexity within the health system and even within one shift in one department. But if we sort of take that complexity and then multiply it, because it's not just our health organisations, it's not just our PHNs and our different medical jurisdictions, but when we think about the stakeholders involved in rare disease, we have many different stakeholders. And this image here is designed to sort of represent those interrelationships and the need that we have to be able to work together collaboratively. And so you've got 10 different stakeholder groups there, and there's lots of different ways you could slice people up. Oh gosh, that sounds terrible. Lots of different ways that you could group people according to the different roles that they play in this complex system. But here, I hope that whichever stakeholder you represent, you can see them represented there. And it's been absolutely phenomenal working with people with lived experience. It's been really central to the RArEST project. And I believe my next honour is to introduce to you Kaila Stevens, who is the Program Manager at the Rare Care Centre, who's going to come and share with you a little bit about what they're doing here.
Hi everyone. Thanks Lauren and thanks Yvonne. So as I was just introduced, my name is Kaila Stevens. I am the Program Manager of the Rare Care Centre, and we were established in February 2022. We're based at Perth Children's Hospital, but we deliver a statewide service, and we have philanthropic funding over 5 years. So I want to start by telling you a little bit about rare diseases. It sounds like there's a lot of you in this room who are very familiar with rare diseases, and I'm probably telling you things that you already know, but given that that's what we're here for tonight, it's good that we all have a kind of same level of knowledge and understanding going into this. So, individually rare but very collectively common. Rare diseases are diseases that affect less than 1 in 2,000 people. In Australia, 1 in 12 people are affected by a rare disease. In Western Australia, there are 63,000 children who have a rare disease. That's one that fills every seat in Optus Stadium. So, very collectively common. There are over 8,000 known rare diseases, and this is growing all the time. We know that there are a lot of strong statistics around rare diseases, and I think it's important to remember that a lot of the statistics are quite negative and impactful. Every child, every person with a rare disease has their own story to tell. So the statistics are one thing, their stories are very different from those statistics. Rare diseases are the biggest health cost in our health system. $2 in $3 in paediatric spending is on rare diseases, and 1 for 1 for adults. Rare diseases have a significantly higher mortality rate for children than all other diseases combined, approximately 13 times higher, and they result in 6 in 10 deaths in childhood. We know that there are a lot of challenges that are faced by children with medical complexity, things like a high burden of care, fragmented care, lack of care coordination, parents becoming the expert in their child's care. But there are additional challenges of rare and undiagnosed diseases on top of these that make it even more challenging. So long diagnostic journeys, often with multiple misdiagnoses, sometimes families never receive a diagnosis. There's inadequate clinical management and fragmented care as children and families are getting the wrong diagnosis, they're not having a diagnosis, there might be tests, investigations that are done that are not necessary, or there might be treatments that are trialled that are completely inappropriate. 95% of rare diseases do not have a prognosis-altering treatment, so clinical trials are often one of the best options, and they can be really difficult to access, particularly in places like WA, where we're very spread out. There's lots of rural and remote places. Parents are not only the expert in caring for their child, but they also become an expert in their child's disease. They might be the only person who has heard of their child's disease before they actually introduce it to someone else. So that can be incredibly challenging when you constantly have to be the holder of all of the information. Because there's so few other people that might have the same experience, there's a lack of peer support, and this is a big contributor to a higher mental health burden. We know that families who have a child with a rare disease and the children themselves can experience mental health concerns at 4 times the rate of other people. This is particularly around isolation, stigma and discrimination. And there's a general lack of awareness of rare diseases. If you talk about autism or ADHD to your friends, family, colleagues, people know what you're talking about. When you start to try and tell them about a condition they've never heard of, it's really hard for them to connect to. They don't understand what you're talking about and what you're trying to engage with them. So as I mentioned, the Rare Care Centre, we started in February 2022 with $10 million of philanthropic funding. At our core, we provide a cross-sector care coordination service. So we see kids and families in our service, and I'll go into a little bit more about what we do. Around our kind of core of our clinical service, we also have a number of capacity building streams of work. So we aim to do work that lifts up rare diseases at a much higher level. We try to connect with partners and people worldwide to do that system level change in lots of different areas. So family supports, digital solutions, education and workforce capacity, training the next generation of healthcare providers, teachers, NDIS workers, how do we upskill them in rare diseases and being able to actually influence what that's going to look like in the future. And then general awareness and advocacy, looking at legislation, looking at policy change, working with system level representatives so we can make changes more broadly. A very important part of the Rare Care Centre is our global partnerships and global leadership. We're talking about rare diseases. You might only have 2 kids in Australia that have a condition, but if we look globally, we might find many more. So if we're working globally, we can have that critical mass of people and we can have a much greater impact. We can also use our resources in a much more effective way and ensure that we're not duplicating anything, we're working together, we're disseminating the things that we're finding out to as many people as possible. And all of the work that we do in the Rare Care Centre is really underpinned by an attitude of innovation, and we try to ensure that everything we do is scalable, it can affect as many people as possible, that we're focusing on equity of access so that people, no matter where they are and no matter what resources they have, can access our solutions. And also that there's some sustainability, that it's going to continue over time and it's not going to end if we run out of funding or if a clinician leaves or if we don't have a particular resource anymore. So our model of care, as far as we can tell, is first in the world. We haven't seen anybody else who's doing it quite like this. So our model of care is cross-sector care coordination. So we aim to provide a wraparound service around families to fill in the gaps in services that they might be experiencing. So not only do we have doctors and nurses in our service, we also have a general practitioner, lovely Claire, who's here with us tonight, who connects us with the primary care sector. We have a mental health clinical nurse specialist. We have a senior teacher who connects us with the Department of Education and with individual schools. We have an NDIS coordinator and welfare specialist, so she looks into the way that the NDIS system works and the welfare allowances that are available for our families. We have a Department of Communities liaison, who can work with us around state-based disability services, housing, child protection issues, anything that might need support from Department of Communities, and also a genetics counsellor. We also have an Aboriginal health practitioner to make sure that we're looking at all elements of care that are important to families. Our model of care was designed with families, clinicians, and across all of our different sectors. When we started the Rare Care service, we set up a consumer reference group, so parents or carers of a child with a rare or undiagnosed disease, and we're very lucky to have Cristian, who's one of our consumers here tonight as well. We have our youth reference group, who are young people with a rare or undiagnosed disease. We have a model of care advisory group, who are clinicians from across different health specialties, as well as from the different agencies like NDIS, Education, Department of Communities, Primary Health. And we also have a strategic level group that represents that cross-sector as well. All of those different groups spent lots of time with us looking at what our model of care should look like. How do we actually make this a reality that's going to be meaningful for families and deliver the best value that we can? What are the gaps that they currently have that other services are not meeting? So with a lot of input and a lot of iteration, our model of care, we're now in our second year of our model of care, and we're receiving really positive feedback from our families. So at this point, our referral criteria has changed over time as we've really started to understand what does the gaps look like and who do we need to be best referring into our service. So our referral criteria is any rare or undiagnosed disease, the child and the family is under the care of a paediatrician, whether that's in the community with the Child Development Service or with a secondary hospital, so not PCH, or they're under a medical team at Perth Children's Hospital. And they have some sort of gap in their care. And that doesn't have to just be health, that could be in another sector like education. We find that many of our families come to us when they're in crisis or when they're in a transition point. So that might be starting school, moving from primary school to secondary school, leaving school and becoming an adult and thinking about finding a job or what they're going to do after school. It might be that all of a sudden their appointments have just gotten out of control. They have so many that they just don't. No one is looking at their appointments and helping them to put them on the same day at reasonable times. Our service aims to maximise value. We don't want to duplicate anything else is doing. All of our families remain under their existing care teams, and we work with them to coordinate their care. We don't take on any elements of their care that could be done by someone that's already there. And this model allows us to accommodate both children and families who have low complexity conditions and high complexity conditions and lots of needs or very few. So it might be that there's a really big issue with education. They can't find a school that's going to work. They haven't started school yet and they might be delayed in starting school, and that might be creating a significant amount of stress for the family that means that everything else kind of falls apart. And as soon as that issue is resolved, they can cope with things again. Or it might be that there's multiple issues across multiple sectors where things quite haven't come together. So there's a whole range of support that we provide for families. Our service is time limited. Families come onto the service. We work at providing them with scaffolding, setting up supports and structures in place, and then once they feel comfortable and all of those things are functioning well, they're discharged off the service. And that allows us to take more families onto the service and continue to provide that support. Families, however, can be re-referred if things seem to be falling apart again or they're not quite working as they were expected. We also provide our clinic off-site. We don't provide our clinic at PCH because we know a lot of families spend a lot of time at the Children's Hospital, and coming back again is not always that comfortable and accessible. So we provide our clinic off-site through North Metro TAFE in Mount Lawley, so families have access to free parking, there's very good public transport links, it's a bit of a calmer environment because it's only our clinicians and our team there. So I just want to quickly run you through an example of a family that we've had through the Rare Care Centre and the kinds of care we've provided. So we had a family recently through the Rare Care Centre who had just received a diagnosis of a rare disease. This young person had symptoms since they were born, but they'd only received a diagnosis in their late teenage years. And in the previous 12 months prior to coming to RArECare, they'd had over 60 appointments across 12 specialties at PCH. So a really significant amount. Some of the impacts of that late diagnosis were that they'd had really minimal access to early intervention and ongoing supports. They hadn't been able to access any NDIS funding, and they didn't really have access to any care close to home. They were coming to PCH to receive all of their care. And we identified during that referral process and talking to the family about what were their biggest priorities, that they needed support in transitioning to adult community providers. They were leaving the paediatric system but didn't have very many supports in place for where they were going to next. They needed help with mental health and looking at mental and community-based mental health supports. They didn't have a GP, and they were really lacking around NDIS and welfare supports. So this gives you an example of all of the teams that were involved in their care. And I'm sure many of you have experience in navigating things like this. But imagine if you don't have that experience, imagine having to repeat your story, explain what you're going through, explain what your past has been to all of these different teams on a semi-regular basis. And probably many of the teams not actually speaking to each other. For what we did for this family is one of the biggest things that was causing them to end up attending hospital was they were having some issues that were neurologically related. So we expedited, in coordination with their primary team, we expedited their referral to adult neurology. So they were able to see a neurologist much faster. We referred them to the Connect team, who do care coordination for complex adults, because once they'd left the paediatric system, they weren't going to have anyone that was really coordinating their care anymore. We identified and upskilled a local GP who had an interest in rare diseases so that they were able to have someone who could help support them in their transition to adult services, and they had someone else who could help hold all of that information for the families. Our genetics counsellor and the broader team created a visual summary, and this is a document that has information about their specific rare disease and the way that it presents for that person, and also the impacts that it has on their function. And this can be used to upskill new therapists, adult healthcare providers, and their GP. So it means they've got a document that they can hand over and say, these are all the things that you need to know about my condition, and so the family doesn't have to hold all of that information. We also referred them to a rare disease specific NGO who could support them, provide support in the community, provide carer support, resources and information. Our mental health clinician provided strategies to improve the young person and their family's mental health, and they created a plan to transition them into ongoing community services, so they had some ongoing scaffolding. In NDIS, our NDIS coordinator guided the family through an NDIS plan review, and we saw an increase of about $116,000 to their NDIS package, which meant they were able to actually access adequate support so that they could function at home, which reduced all their presentations to emergency and the number of admissions they were having. And this funding also really meant that the young person could have access to increased supports in the community, and so they were able to have increased social, economic and community participation, which helped their mental health, their family's mental health, and they were all much happier for it. And we also supported the young person with an application for the disability support pension, which gave them a bit more independence and choice around some of the activities they were able to participate in. And the mother was assisted with applications for carers payments and guardianship so that she could continue to support her child ongoingly. So this is an example of what their hospital journey looked like over the 4 years, including what's expected with their current appointments. You could see in 2022 they had a really significant number of outpatient appointments that were all based at PCH, which wasn't their closest hospital, so they were having to do a significant amount of travel. Once they were referred to the RArECare Centre, we started transitioning some of those appointments to other healthcare providers in the adult system and to hospitals that were closer to home. So they were able to have a much shorter travel time and be able to transition into the new services. You can see after the NDIS review, they were able to access the community neurological nurse support, which also provided significant support and helped to reduce the number of times they needed to present to emergency. And the purple arrows down in 2024 are their planned appointments for the rest of the year. So already we've tried to reduce them significantly and coordinate them much better so they have to attend hospital significantly less. So our next step, we've successfully set up our model of care in the metro area. We've delivered to approximately 150 families in the last 16 months. So now we're looking at expanding into the Pilbara. So we know that in the Pilbara, there are really disproportionate rates of burden of disease, health disparities, and a lack of access to healthcare services. There are approximately 3,000 children in the northwest of WA who have a rare disease. We know that there's sometimes telehealth and outreach clinics work really well. However, they're never going to be as good as site-based care. In order to provide equitable and direct access to care and to build capacity in a region, you have to actually provide care where people live. So we're starting with our same model of care that we've been providing in the Rare Care Centre, and our first step is working with the community and with the healthcare providers and all of the other sectors in the Pilbara to localise that model of care to provide place-based care, while still enabling those formal linkages to the Rare Care Centre and all of the capacity building elements of work that we do, and the specialists who are much less likely to be able to access in the Pilbara. But we can do that in a much more supported way, having a rare care team in the Pilbara that can connect with the rare care team in Perth and support patients and families in that conversation. I think everybody in this room knows where the Pilbara is, but we quite like showing this slide when we present this overseas and just shocking people how far Port Hedland is to Perth. It's the same as, if you were to travel to Portugal from London to receive care, and people say their patients often complain about, an hour car trip to get to them. So it's nice for them to understand just the remoteness of some of WA. And so similarly, we'll be looking at how we make our model of care work for Pilbara families. Our cross-sector care coordination model really encompasses navigation, coordination, integration and advocacy. There are 4 pillars of what we do, and we look at how we connect families to services in a centralised way. So they don't have to connect with each service individually and have to manage all of that by themselves. We try and wrap everything around them. The model is also two-way, ensuring that the voice of families influences how we iterate our model, how the model is delivered. It's what they want in the ways that they want it. We work with extensive numbers of partnerships to really leverage existing infrastructure, so we don't have to spend money on building buildings, and through shared governance models, so we can not take away workforce from other really important areas. So, for example, in Perth, a lot of our staff are fractional FTE. They work 2 days with us, 2 days somewhere else. And that creates a lot of really important capacity building, because it means the message about rare diseases is also going out into the other services that they work in, and they're bringing those experiences and connections from their other services into rare care. So integrated care is extremely important to everything that we do at Rare Care, and our next step very much is to take that into rural, regional and remote areas of WA and how we spread that across Australia.
Thank you. Thank you so much, Kaila. It's amazing, incredible work. And after we have dinner, we're going to talk about how we can do more of this kind of work, not just in WA, but elsewhere. And it's really amazing that you're spreading this work to, rural and very remote regions in the Pilbara. That's incredible. All right, next we're going to hear from Andrew. Andrew, please come up. Andrew's Rare Voices Australia Ambassador, and I've heard Andrew speak many times. Thank you so much for agreeing to talk to us tonight.
I'm Andrew. I'm a Rare Voices Australia Ambassador and Rare Care Ambassador here in Perth. I was born with a rare bowel malformation, PVNH, PMD and CH. I got diagnosed when I was 17 years old from Professor Richard Revente at the Royal Children's Hospital in Melbourne. I am now 32 years old. When I was young, I had many appointments, and when I asked what my diagnosis was, my mum and dad would reply Andrew syndrome. When I met Professor Revente, me and another geneticist, a couple of years after I got my diagnosis, they said I was one of 17 in the world. They also said I would finish 100-meter race before any of the other 15 people leave the start line. My parents were told I would not speak, but they were wrong. I went to speech therapy for 15 years. It was hard in high school because I was bullied due to my poor speech. This was my first sentence I spoke in my life with friends on holiday to their days of over. That photo is from November when I went to the bottom of the world to take that photo with my banner. And thank you.
Thank you so much, Andrew, for sharing your story. It's amazing. I'm going to ask Amanda to come up and tell us about her lived experience. Thank you, Amanda.
Hi, my name's Amanda and I'm mum to Holly, who you can see up on the screen. She has a very rare disease called CLN5 Batten disease. So on the 9th of April in 2021, our entire world was turned upside down. After almost 2 years of searching for answers, which in the scheme of things with rare disease is probably quite a short period, we got our answer and it wasn't great. She was diagnosed with a very rare form of childhood dementia. So a once very normal little girl who could run, talk, jump, met all her milestones, was going to lose all of those bit by bit. She is currently the only child in Australia with her variant of Batten disease. There are other forms of it, but she is one of the more rare forms, and there's roughly about 30 in the world that we're aware of. So living with rare disease, it constantly feels like you're fighting for every single thing that you need. From pre-diagnosis, when you have to fight to get things done, asking questions, can we try this, can we try that? And I feel that I was lucky to have the medical knowledge that I did, that I could push for things. And I think that's the reason that we got our diagnosis a little bit earlier, because I wasn't prepared to just go with the flow. We needed answers. And eventually we did. But not everybody has that ability, and that is something that I'm very passionate about, helping those families somewhere in the future, because not everybody has that voice or the knowledge to be able to do that. And then once you get diagnosed, you constantly have to advocate for good health care, for NDIS, for equipment, for you're having to constantly retell your story because there's so many different team members and nobody knows what you're talking about, and you have to tell it over and over again from start to finish to give them the bigger picture. The huge constant mental load that you have, I mean, each rare disease is different. Holly's is a life-limiting condition, so not only do we have to work at keeping her strong now and maintaining her quality of life, which is number one, we also bear the burden of the fact that she's not going to be with us for very long, and that is a lot to live with. And watching her lose those abilities little bit by little bit is heartbreaking. Living remotely, the girls were born and bred in the Pilbara in Karratha, and we lived there for 12 years, and it was an amazing time in our life, but it also got to the point where it was too much living where we were, and we had to relocate down south to Albany, which was very hard to do. It was the one place that Holly was known just for Holly and not for her disease, along with the beautiful life that we'd made there. But living remotely also adds to the isolation when you're the only person with a condition and you already feel like you're suffocated by that diagnosis. Then you're living away from your family, you're living away from the bulk of your medical team and trying to deal with all of that on your own effectively. And then I guess the other aspect is every hope and dream that you ever had was shattered in a single day. You need to alter your ideal of what is the perfect life and how do you change that so that you still give your girls the most incredible life as best you can, but with outside every aspect of what you thought it was going to be. And then there's dealing with the grief that you live with every single day. So living in Karratha definitely had its challenges. Not only was the bulk of our care in Perth, So Holly and I were constantly flying down to Perth for appointments, which I'm very thankful for Pat's, because we would never have been able to afford it otherwise, or zooming in with telehealth and things like that. However, when it comes to the therapy side of things and the allied health side of our team, up there we actually had everyone under one roof, which is apparently not as common down south. So that was a bit of an eye-opener moving to Albany. The Rare Care Centre was amazing assisting us with our move, because it is very daunting moving with a child with a very complex medical condition, and there's many elements to consider when you move that need to be taken into account, and setting up the teams so that you know that they're getting the best care possible and things keep rolling along. Albany, on the other hand, there is many lack of services. When you would think living 4 hours from Perth there would be better services, but unfortunately that hasn't been the case. We've already had multiple changes with different therapy members, with OT, physio, speech has been, we've had to use fly in, fly out speechies. It's been a challenge. And the other big thing is apparently no one down there likes to talk between the teams, which, coming from a team where everyone just worked together and spoke, was amazing. Down there nobody likes to, because they're all from different businesses and they don't like that multidisciplinary team approach, which is crucial in Holly's care. So I'm trying to retrain them with that, but that's a work in progress. So this isn't just a random photo, it is actually one of our favourite places in the Pilbara at the Dampier foreshore. Things that we've learned along the way, I guess with the road to diagnosis, always follow your gut. I unfortunately like to try and ignore my gut when it's screaming at me, but it generally has been right when I don't want it to be. But that is a big one. If ever in doubt, get a second opinion, especially with things rare. It's outside the normal scope. You know, the amount of times we're like, oh, maybe Holly's autistic, or she's this, or she's that. And hey, I would give for her just to be autistic these days. I would give anything for that. But yeah, you need to find your team that will fight for you, listen to you, include you in all aspects of care, and lock in those amazing ones, because they are unfortunately hard to come by. Paediatric and clinical trial options are hard to find. We had to find those ourselves. We got given a website we could look at that had every trial in the entire world, but we had to find that and source that information. And that goes with a lot of things. We had to source things, and again, that was us not being prepared to just sit back and go with the flow. We searched and found things that we needed to at the time. Advocacy and raising awareness has become very important to us. Not only does it help find cures and opens research opportunities, but it improves care for people with all rare disease. And as we have spoken about earlier, collectively there is thousands of people impacted by rare disease. Holly might only be one in Australia, but collectively she is a part of a group of people that is of thousands of people. And these guys need to be looked after in the same way people with cancer or other more common conditions are cared for with. Not being afraid to speak up to your medical team, which can be hard because you expect the teams to be the expert, and sometimes they're not. They like to, hopefully most of the time, they will be willing to work with you and listen to you, and also put things across in a good way. I mean, an example of that is I'm a nurse, and so I am used to the way that doctors can speak to people at different times, and so I'm a bit harder in that way, whereas my husband is not medically based or trained, and sometimes people have come across with things in a very direct manner at a very crucial time, such as when Holly was first diagnosed, and that doctor is now someone that is crucial in our team, but he does not have full trust of, and he is very hesitant with, because of the way they came across with certain bits of information, and they weren't willing to listen at that time. And that can be the difference between good care and fractured care. And I guess the other is, the big thing that we have learnt is you can't care for others if you don't look after yourself. And again, that is where our teams can help support us in looking after us too, because while Holly is affected by this disease, it impacts every aspect of our life, and our other daughter's life, and my husband and my life. And finding team members that acknowledge that and approach that and include that in the care is huge, because not everybody does. And I guess last but not least is staying ahead of the disease, and that's where we've struggled with NDIS at times, because they often are looking at diseases that if you work hard and you do this physio, then that person will get stronger and they'll get better. With Holly, it's about maintaining the skills she has for as long as possible to give her quality of life, and they don't always understand that. And the time that it takes to get equipment and things, you need to be one step ahead of that, and we learnt that very hard early on in the piece when we had a very quick decline in her condition. And we suddenly were with a daughter that could barely walk and do other things, but we had nothing to support her with that. And that also means us getting our head around accepting that she needs these pieces of equipment all of a sudden, which is, again, huge mentally. But if you can stay ahead of the game, then you can help that person a lot better and at the end of the day, quality of life is number one. So I've just got a few different photos of some of Holly's adventures. She's a big animal lover. She's a Pilbara girl at heart, and she's a little daredevil. She loves The Descendants and had a wonderful time in Disney when we were over there in 2022. And she loved ballet, and it was the very last activity that she could do normally before the disease started taking over. But she's a cheeky girl, and she's got a long road ahead, and hopefully we can provide her with the best quality of life with an amazing healthcare team. And that's about it.
Thank you so much. So much in that story that I think will resonate with lots of people who have lived experience of rare disease. Equity, being listened to are the two things I took away from your story. It's so important. I'm going to invite Cristian up next, please.
Thank you for being invited to talk here. I actually don't have any slides, and I'm aware we're probably late for dinner, but we're lucky because Kaila's mentioned a lot of things I was going to mention, and Amanda's story was absolutely amazing, and there's no way I could... a lot of things she said ring true, basically, to what I'm about to say as well. So our story is very similar to both Andrew's and Amanda's, although obviously Andrew living with it. Our son Max, who's just turned 8, has a very rare disease, one of 2 or 3 in Australia, one of about 80, maybe 90 in the world. Only diagnosed last September, so he was 7, so the average age of diagnosis for rare diseases. Our journey started before he was born, so it took us 6 years to conceive and spend a lot of money on that before finally having a miracle and then being hit very early on, within probably 6 to 8 weeks, realising that something was wrong. So as with a lot of diseases and syndromes, there's a wide array of the spectrum. Max, through joining a Facebook group. It was the first time I've ever been on Facebook in my life. I joined Facebook to join the group for his syndrome because there's so little literature on it. When we were diagnosed by Gareth, who heads up with Sue the Rare Care Centre, I think there was 1 document, maybe 2 documents on it in the world on his syndrome. So I joined the Facebook group to find out a little bit more information on it. And it seems that Max is at the severe end. He's non-verbal. All the other people with the syndrome are talking generally by the time they're 5, and he's non-mobile. But PUF60 syndrome, they called it for Hage for a while, but there's a few little variants, so they've just gone to the gene effectively and called it that. There is a sidebar. There is one professor in Cologne, Germany, doing a study on it. He's the only person sort of researching this syndrome in the world, so we're able to join that group and be part of that study, which is good. But yeah, so our journey has been one of, because he was undiagnosed for so long, it was really us just trying to do the best for him in his life. So starting with therapy and seeing a neurologist from early on. His original concerns from the specialist was around the size of his brain, and there was fears that it was the brain matter was reducing in size. So he had a number of MRIs very early on. in his life, and then he started suffering seizures, which went on for a number of years. And we were very fortunate to get that under control, and he seems to have grown out of the seizures, which we're very fortunate. I guess for the discussion that we're talking about in terms of the care coordination, and Amanda articulated it very, very well in terms of the challenges that you face as a parent, and I guess understanding what a great model of care looks like, the Rare Care Centre. And I was lucky enough to be invited, as Kaila said, to be part of the consumer reference group, and which helped co-design the centre. And I've actually spoken to a number of people that have been through the centre, and the feedback is amazing, and everyone that's been there feels very privileged and lucky to have a team so dedicated to supporting all aspects of the challenges that they deal with on a day-by-day basis. And I guess for other families like myself, you just do the best you can, and you take on that sort of responsibility, and trying to, I guess, work through coordinating the care for your child, not just in the health department, but obviously the other aspects of life, whether that be education or therapy or what have you. But it is challenging, it is frustrating, it is a big burden. My wife hasn't worked since Max was born. She basically became the primary carer, and we were lucky enough to be able to do that. But now navigating, whether it be school, the NDIS, his health appointments, etc., it's a pretty almost full-time job, to be honest. Plus caring for your child and trying to be a mother and a father at the same time, and trying to live your life as happily as you can, and make memories. So I guess some of the thoughts that I had around support and care coordination were that understanding centres like Rare Care Centre and other opportunities are going to be limited in the amount of people they can support, and that's only natural. But also understanding that rare diseases generally come with a number of issues associated with it. And I think one of the slides Kaila put up there had that you see 50% of people see up to 10 specialists, and I guess from the people that I know, in walking in these circles, that's very true. We count ourselves quite fortunate and lucky with Max in that he doesn't have some severe health issues. We definitely do count ourselves as lucky. But there are still a number of specialists that we deal with at PCH, a number of appointments, and the coordination of that obviously is all on us. And I guess one of the thoughts I had would be whether there was an avenue to have a care coordination centre, not centre, but just even a person that you can contact to help coordinate maybe just the health appointments, and something as simple as that, because that would be a stress relief on families. You have to do everything else, you take it on. But it's taken us 8 years, and a lot of work to even just coordinate a couple of our specialist appointments, to have them on the same day, have these x-rays done on the same day. One's for hips, one's for spine. They're basically the same x-ray. And the specialists literally sit next to each other. And sometimes you were coming in one day and then coming in the next day and spending 4 hours here one day, 4 hours the next. So, I thought in terms of small steps, if people with rare disease are offered that opportunity to have just a care coordinator. Obviously, in an idealistic and future world, the model of care that Rare Care Centre operates is able to be expanded and provided to more people and more families. But I thought as a small step, that would be a great help to families, certainly to a family like ours. That would be a big burden and a big relief. And I guess the integration to GPs or PEDs or whatever, that's probably the next step, because certainly, a lot of the departments, even within the same hospital, and I think, Amanda, you mentioned it, they do work in silos, they don't talk to each other, and that can be a big frustration. And even, I guess, when you turn up to an appointment, and if it's a neurologist, they're obviously back to back and very busy, and you're normally waiting, and you sort of walk in there and they just quickly pull the file out from under the desk and reread your notes so they can refresh their memory as to who they're actually talking to. And that's probably usually about the first 10 minutes of your appointment. So, yeah, I think something like that would be helpful, for all families. To a couple of other Amanda's really good points, I think sharing knowledge is a great thing. So peer support networks and KIND, which I'm part of, and Carrie's here, that do a lot of peer support networks, family-led peer support networks, and sharing of knowledge is great. I was with a few other dads on Saturday, and just in a short space of time we were all giving each other pointers and tips about things that we've learnt along the way, and you don't know what you don't know, and other people that have walked the journey often have really good, helpful insights, and you can pass notes to each other. So I guess sharing of knowledge is great. And I guess another point to steal from Amanda is, I think speaking up for what you think's right and speaking up for your child and your family is critically important, whether that's with your teachers or whether it's with your specialists. And if you're really not happy, asking to, if there's something else or someone else that you can move to, not taking no if you feel like something's really not right, and asking if there are other, opportunities or research out there or alternative options for what you're being presented. So, and I guess that's all probably well and good if we're able to advocate for yourself, but I guess there's a lot of families out there that aren't, and so having someone there that's able to support them, and I'm sure that's probably the case in the Pilbara with a lot of families there that again don't know what they don't know, and even though if they'd like to be able to advocate for themselves, they probably might not be able to and can't. So I guess having the support of either their specialists or someone like Rare Care would be again critically important. So I'll wrap it up there so we can have something to move. But thank you for listening.
Thank you so much. I think you hit the nail on the head. Care coordination is really important to break down the silos. And that's something that we talk about a lot. It's really hard to do. But I think the next thing we need to do is actually discuss how we might change the systems. So we've got some really good examples. We've got the Rare Care model, but we're still hearing, difficult stories from people with lived experience.